Hello and welcome to another episode of Oncology for the Inquisitive Mind. I'm Michael, that's Josh. You can't see him because it's an audio medium, but we have a very special guest with us today to speak about gynecological cancers. Dr. Vish Boolell. Vish is a medical oncologist currently working at Victoria's Northern Hospital. A proud Mauritian, he speaks at least 3 languages that I know of. He probably speaks more. He is a graduate of the University of Melbourne and completed his oncology advanced training in 2014, a journey that took him across metropolitan Melbourne and regional Victoria. He has held research fellowship roles at Monash Health, Ballarat Hospital, as well as the Hudson Institute. He worked for many years at Ballarat as a consultant oncologist, also providing outreach services to the rural community of Horsham. Finally, he moved to the Northern in 2021 with the brief to establish a Gynae-Onc service for Melbourne's rapidly growing northern suburbs. There, he met a wide-eyed, know-nothing oncology trainee who later would drag him kicking and screaming onto his podcast. Vish, it's a privilege to have you on the show. I hope I didn't undersell your oncological or linguistic abilities.
Probably slightly. Thank you, Michael. But yeah, four and a half languages, actually.
4.5. I knew I was underselling it. So, Vish, we do like to start these with a little glimpse of you. You know, we can provide the myriad intellectual accomplishments, but we like to ask you a couple of questions of how you got to this spot. So, you probably could have picked any specialty in medical school and after finishing your basic physician's training. What drew you to medical oncology?
Yeah, good question. It's I suppose the answer has been the same. When I was in medical school, I already sort of developed an interest to it, probably more the science part of it. And I actually did my elective in medical school in oncology back in my home country. I have to say it was a terribly negative experience. It was very barbaric medicine, not very nice, not very kind. But didn't sort of deter me. And then when I started training, my first ever job actually was oncology intern in Bendigo. And that showed me a much better perspective of what oncology could be and kind of consolidated it. I think there's 2 components to how I answer the question. The first one is the science part of it. I don't think there's many other disciplines in medicine where you can go from a molecule all the way to being able to get a drug that targets that molecule and actually get a response. So I also feel that a lot of other areas of medicine have a lot of good treatments already. So you're really sort of just improving on very good management levels. And this is really an area of need. A lot of parts of oncology, the outcomes still aren't that great. So there's so much work that still needs to be done. I also think on the opposite side of it, the human aspect of it, and it's one of the few areas where you actually get to sort of truly talk to someone as a person. And you know, you've got the 2 speeds of oncology, which is you can cure someone, but a lot of times we can't. And, you know, and then the patient then comes a lot more at the forefront of, you know, what treatments do you offer, trying to maximize quality of life and talking openly about, you know, the end coming and what to do. And so I think on a human aspect of it, it's actually more rewarding. And that's been the sort of 2 main reasons I do it.
Oncology definitely has a very holistic approach, or has turned very much into holistic care of patients, where we become the primary physician and the primary carers for a very long time for these individuals. And one of the questions I have, there's a plethora of things you can go into in oncology, including becoming a clinician scientist, but why did you end up fellowing and sort of pursuing gynecological oncology as a subspecialty?
So I think a lot of what you end up doing comes down to the experiences you've had through your training. So I had the benefit of, being exposed to pretty much all the different types of solid organ cancers. For a huge chunk of my early consultant career, I actually worked regionally, so I didn't have the luxury of being able to subspecialize in tumor stream. And so you sort of take on everything. You tend to find affinities to different malignancies based on what your experience has been with them. And I think, specifically with gynecological oncology, there's a lot you can do, and it is a bit of a within oncology, a little bit, not so much of a dark art, but just something a lot of people don't get exposed to because there's a lot of centers that don't provide it as a service. A lot of that is tied to the gynae-oncology sort of surgical subspecialization, which means that these patients need to be seen and sorted by a center that can provide that service, and there's not many of them. But also, I found that the patients a lot more, grateful for the input, and also that you actually can make a true difference to someone's survival, but also their symptoms. I'm not a clinician scientist. I'm a true clinician. I did work in a lab. I have done a fair bit of lab work in my life, but I think one of the key things to learn in your life is see where your skill set takes you, and also what gives you more professional satisfaction. And for me, that's really very much in the clinic. And I just find that other cancers, there's a lot of attention to. There's a lot of media attention, but a lot of awareness, support available. Breast cancer, for example, but even lung cancer now, and prostate. But gynecological cancers are really not spoken about in that tone. They are rarer, but you can actually do a lot of good to patients by being able to provide treatment closer to home for them, rather than tie them to bigger centres where they sort of have their surgery.
You mentioned, Vish, working regionally and rurally, and you've done quite a bit of that both as a trainee and as a full-fledged specialist. Do you have any vivid, I guess, memories of the specific challenges of working in regional and rural areas, having experienced both metro and regional medicine?
Yeah, look, I think working regionally has its challenges in the sense that there's less of you. You do have to be across a lot more cancers. So from a professional standpoint, sort of getting comfortable making decisions in areas where you might not have the same expertise as one of your colleagues in metropolitan Melbourne. I didn't find that to be that big a challenge because one of the key things to anyone who chooses to work regionally is to have a good address book of people you can call for advice and help when you're faced with specific cancers where you're not sure. It's very difficult, and I think it's really becoming harder and harder to be across everything in the right level of detail, but not just therapies, but also opportunities for trials, opportunities for testing, molecular testing, availabilities, and capacity. All these things get harder the further away you are from a metropolitan centre. And also subspecialization awareness. So, immunotherapy and toxicities, how you manage that when, you don't have a very well-developed gastroenterology service or respiratory service, and sort of taking on a lot more responsibility by yourself. It is challenging, but I think it's important for people to understand help is available if you just know who to call. And so having a list of people you call and contact when something goes wrong is always important. And, and I suppose sort of building on good practices that you've seen elsewhere. So if you're setting up somewhere where there's probably not as much service, but, getting your MDMs to a robust standard, pathology services. None of us can function independently. We're fairly useless as a specialist on our own. Like, you need nurses to deliver the treatment. You need a big sort of multidisciplinary team around you to look after the patient. And so if that's not accessible, there's a way to access it and building that through. On a personal level, I'm not born in Australia. I am clearly of a different background. I think it is a little bit harder to implant yourself in a sort of regional setting, coming from a different cultural standpoint and looking different to everyone. I always use this analogy of me being at Bunnings in Ballarat. I just stood out like a sore thumb, and everyone knew who I was. I think almost every one of my patients would come and see my child when I'd walk into Bunnings at the time. And it takes time to sort of get comfortable with that. I can't say I've had negative experiences because of the way I look. I think, unfortunately, idiots live everywhere. So it'd be quite similar experience you'd have in Melbourne versus regional. I think people in the region are a lot more grateful for the help that you provide, and you do feel sort of more part of a community. And certainly, having looked after a lot of people, even after they die, their relatives, you still bump into them at the supermarket afterwards. It is smaller, but it's actually, you do feel that you're part of a nicer community over time. So I do recommend it to a lot of people. I don't think sort of having to do more tumors doesn't necessarily mean it's scary. It just means you need to just know where your limits are and where to ask for help. And you're not expected to know everything.
Very wise words. And for our international listeners, Bunnings is like a Costco or I think you could call it like a Best Buy or any of those big sort of warehouse type shops.
Home Depot,
Home
I think,
Depot, that's
is the main one. Yes.
Vish, one more question. We always have so many questions and such little time on this show before we jump to gynecological cancers is for someone who, lots of people in medicine move. Either they move before university or
Mm.
they move during university or even due to work circumstances and life circumstances. What did you find as the biggest challenge and or reward from going, I guess, from somewhere like Mauritius to, let's say, Australia?
Look, for me personally, moving was always sort of on the cards. So um, when I when I certainly went through high school, we didn't have the capacity to do any medical training in the country. That's changed since. So it was always a question of moving somewhere in order to do university. We sort of, my family, really more than me, picked Australia more. At the time, it was more affordable than going elsewhere, and it was quality education for less money. It is challenging moving. I think early in your life better. So I came here at 18. I think it was fairly sort of smooth transition from my perspective. I think moving around through training sometimes it gets harder the older you get, and not necessarily because of age, but because of the different parts, the different phase of your life that you're in. So I think being 18, being sort of straight out of home, was probably quite straightforward moving somewhere. Like, it was lonely, but you just kind of had to tough it out a bit. I remember the first time I called home just to go feeling a bit down. The answer I got back from my parents was, "We're paying enough for this education, so suck it up." And you sort of find a way to deal with it. As time has gone on, I think moving from Melbourne to regional Victoria it was a big transition. So, because you've made a lot of contacts, friends. I've actually got more family in Melbourne. My sister lives in Melbourne. My in-laws live in Melbourne, and a few of the extended family as well. And so moving from there to Ballarat was probably a big step. But it was also at a time where my wife was pregnant with our first child. Was a huge change, I think, for that. It realistically took us 3 years to feel like we belonged in Ballarat, just in terms of making the community, network connections, new friends, new groups. And for anyone out there who sort of is in that phase of their career where they're starting a family, it's a very isolating experience, because once you've got a child, your world revolves around your child, and then you still have to do your work. So there's very limited time to actually socialize with other people, other than socializing with other first-time parents who are just as stressed and sleepless as you are. So I think that's probably a bit harder. But the key point being, I think in this day and age, you have to be flexible with your oncology career. Your dream job that you think you'll get, it might not be there by the time you're done. You'll find that there's always work to be done. And I'm living proof that there's flexibility no matter which time of your career you're in. So I certainly sort of, I didn't set out going to regional thinking I would come back to metro, but the right job came along and I came back. Moving back from regional to metro is probably the biggest thing we had to do, because then it's 2 children to move. That was a lot more challenging the second time. I think, though, once you're sort of settled in your family life, moving is much, much harder.
To paraphrase Harrison Ford, it's not the years, it's the mileage. Vish, I'm sure we could talk about the pros and cons of regional, your experiences, your vast experience, for hours and hours and end. But in the interest of time, I would like to start picking your brains about Gynae-Onc. And I'd like to seize on something that you mentioned earlier in the episode, which is the amount of good that you can do for patients with gynecological malignancies, because Gynae-Onc has its own set of challenges. There's the Gynae-Onc problems, there's horrible ascites, there's the incidence of malignant bowel obstructions for younger patients, there's fertility issues. Could you speak to some of your experience in terms of the particular challenges that managing patients with early or more likely advanced gynae cancers presents?
Yeah, look, that's a very valid point. So, unfortunately, gynecological malignancies. So you separate into, your endometrials and ovarian versus, I suppose, more the squamous cell types of vulva, vagina, and cervix. And the patterns of disease and spread are a bit different, and the challenges are a bit different. So, you move from your sort of endometrial and ovarian tend to spread peritoneally, so you tend to get more peritoneal disease. And the majority of women you'll find you will look after will be in that position. So they're incurable from the start. But the survival curve is very different depending on how they respond to treatment, depending on how they also, what type of surgery they get, if they get surgery. Some of the complications you'll find, recurrent ascites, it's probably one of the more difficult ones as it gets more loculated as time goes on. It's sort of become a bit less of a challenge over time, especially now because we use a fair bit of bevacizumab to try and reduce ascites. And bevacizumab recently came off patent, so it's now available, and there's data to use it beyond the beyond the platinum non-debulk patients that we had before. So previously it was only for suboptimally debulked patients or patients who wouldn't get surgery, and you could only use it for 1 year. But now that it's unrestricted, you can actually combine it with your later line chemotherapy. And so that's become a bit less of an issue. Malignant bowel obstructions, that's probably I call that one of the harder way to die, one of the hardest ways to die, because it's really terrible because, and you can see the patients who will have this, it will just start, they'll get the one, you'll give them steroids, they get better, they go home, and then, next week they're there, the week out, and each time that interval changes. Sometimes they're still quite chemosensitive, so you try and get some chemotherapy in to try and prevent this from happening again and again. It is one of the most difficult things to look after in real life in terms of clinical management. I think once you get someone, I usually tell my patients this, once they get a problem with bowel obstruction, this is the start. And it will happen again. It's a question of time. We can use different tricks and techniques to delay, but this will become the norm, and you will get to a point where the steroids won't work, and then this is it. And it's there's not been a lot of clever tricks or things that work. There's been thoughts in the past, if you've got a point obstruction, could you do a diverting stoma? The reality is, even the ones who get that, it's just delaying it a little bit further. It's just going to block somewhere further up the chain at some point. And you need to be very kind to your surgical colleagues about that. So sometimes you get these patients coming back and there's a point of transition on the scan, and you keep asking your surgical colleagues, why don't you do a stoma? And they'll keep pushing you back. There's a good reason for that. What you see on a scan with ovarian cancer or with endometrial, what you'll see in the omentum or in the peritoneal space, think of it as the tip of an iceberg. So what you're seeing on the scan is so much worse when you actually open up. It's going to be a carpet of malignancy. It's going to be grains of sand everywhere stuck through. You're going to cut into it. Normally, if you're trying to enter the abdomen, you want a bit of space between your omentum and your bowel so you're not perforating as you go through. It's stuck on the surface, so cutting through, high chance you actually perforate them, high chance you can't dissect and make a stoma. And then also the problem is that if you get cancer in the base of that wound, it doesn't close over, so you end up with a completely fistulized to surface situation as well. So surgeons are quite reasonably cautious about entering abdomens that have significant omental disease. And that's I suppose the complications you get from the sort of ovarian endometrial when you're looking at the sort of more locally advanced squamous cell cancers of the lower genital tract. It's more this locally invasive mass that just keeps growing despite everything you do. So think anatomically, you've got vagina, cervix, vulva, but as the mass of cancer advances, it pushes front and back. So front is bladder, back is bowel, and it's just going to become like this football that just grows. And very often, the worst way to describe it to patients sometimes is like, it's like them just it's the same pains they would have had if they ever had pregnancy. It's just there's no reward at the end of it, and the pain just escalates and your body can't adjust. So the natural response to pregnancy is ligaments loosen and body adjusts to a growing fetus. That doesn't happen with malignancy. So it just replaces and damages everything. So you get this horrendous sort of pain that's very hard to look after with worsening fistulization as well. That's much, much harder. In the past we talked about exenterations or even diverting stoma and ileal conduit. Even that's not, if you do that, if anything, you tend to make things worse rather than better, because the mass keeps advancing and you just get worsening pain and lymphedema throughout.
I think as a summary of what we just discussed, I think it's that doing surgery on these patients should be done cautiously and potentially in select individuals, given the risks and potential complications. We're not a surgical oncology podcast, so I'm not going to go into more detail about sort of which individual you might choose. But with bevacizumab, and especially earlier in my training, there was a lot of kind of education and I guess a discussion regarding toxicity and management. From your experience, what would be sort of the things you would look out for, given that bevacizumab is now off-label and is probably going to be used more and more and more with your patients?
Look, I think that the challenges with Bev is realistically clots is a problem, and so the bigger doses you use, the more the chance of it. You'll get some of your patients who actually tend to clot no matter what, and the Bev does raise the risk of that. Blood pressure, I haven't found that to be much of a challenge. I haven't actually had too many problems with renal, with proteinuria in the gynae populations that we treat. The risk of perforation, I think, is we do talk about it, but I can't say I've ever seen it for gynae tract malignancy. I think overall it's actually been quite safe to use, and the benefits far outweigh the risks from my perspective.
And just also to seize on something that you mentioned, Vish, both regarding bevacizumab and the conundrum of peritoneal disease, there's various approaches that are used by some sort of hyper-specialist centres, things like HIPEC or intra-abdominal bevacizumab. Have you ever seen those used to any great effect? I know they're very controversial.
Well, no. So I haven't seen many cases. Probably in my whole time, I've probably seen one or two who've had sort of intraperitoneal chemotherapy. I think it's very select cases. It's very special. It's very much dependent on surgical input. I don't think most of the gynae-onc surgeons in this state would do it or would sign on to it outside of a trial situation. When you look at the data around these, and I looked at it a while ago, it looks really good from disease-free interval and R0 surgical resections and survival. But, when you look at the overall numbers these trials are sort of reporting on, it's very small numbers. So they are very, very selective about what type of patient they're putting on. So I'm not going to say it doesn't apply to everyone, but I don't think it applies to the bulk of patients. And, there's emerging sort of evidence now. We talk about when do you do debulking? Do you do it at the start or, post some neoadjuvant? And, ultimately, if it's resectable at the start, they go to surgery. If it's not, they have chemo first and then an interval debulking. But there's actually recent data suggesting potentially that second approach does not lead to an overall survival advantage, which is kind of going against what traditionally we've always thought the role of surgery to be. So there is a point of us where naturally we tend to think, well, if you can resect and you get an R0 resection, they will live longer. But I think as we're learning a bit more about subtypes of cancer, I don't think it's as mappable across the entire gynae spectrum, especially when we're talking ovarian, peritoneal, primary peritoneal disease or fallopian tube. I don't think it's mappable to the entire cohort. And I think as we'll learn a bit more about subtypes and biomarkers, you might end up finding that some don't benefit from the surgery at all.
Precision oncology is coming to all of the centers and all of the subspecialties that deal with cancer. One of the big points in gynecological cancers is the use of platinum and platinum-resistant and refractory disease. What's your process for identifying? It's like you've had treatment, you've either recurred or you're not responding or you've relapsed. Do you have sort of a guidebook on when you sort of look for the next line of therapy?
Yeah, I'm a big fan of sort of planning a bit early. So, obviously we're talking about high-grade serous ovarian, tubal, or peritoneal disease. So I think you're going to, it's amazing how many of these discussions we sit through as a complex meetings talking about all these patients, and the end answer is always carbotaxol. So that's become it's a bit of a running gag that we talk a lot about biomarkers, subtypes, and it's still the platinum, the wall of it, basically trying to see who responds, who doesn't. So in the high-grade serous cancers of ovarian, tubal, and paraperitoneal, the response to platinum really determines survival. So as long as they're sensitive, you could re-challenge. The way I would look at it quite simply is you're going to give it to everyone. Once they're past it, it's from the last dose of platinum they've received, when do they actually relapse? So if it's over 6 months, they're still sensitive. If it's under 6 months, they're clearly resistant. And if they're sort of just around that 6-month mark, you just, you'll take a chance, but you're not too sure, is the short interval of it. There's testing, sort of precision oncology part of it is about to change again. So at the moment, we're only sort of MBS refunded for BRCA1 and 2 testing, and that's both germline and somatic. So, if you do the somatic testing on tumor, you do need to sort of get that to be able to get BRCA, and that's because there's funded medications with olaparib as a PARP inhibitor for the BRCA mutant population. But at the moment, we also know that there's probably about 30% of these patients that carry a HRD, so homologous recombination deficient component, that could also benefit from a PARP inhibitor, and they're missing out at the moment. So there is in Victoria now, well, in Australia now, an access program to get proper HRD testing done, which is funded through the company that actually owns olaparib, and that program is going to run instead of the BRCA testing. So instead of doing BRCA test, we're now going to do a panel test for HRD, and if your patient has HRD, they then would qualify for maintenance olaparib after their platinum doublet, but that would be first line and in combination with bevacizumab, which was basically part of the landmark trial. But down the track, PBS will probably also approve niraparib in the same setting, but without the bev. So this is what's coming now to us. The sort of testing that we're going to do will be sort of testing for known HRD mutations. It's different to the trials. So in the trials, they use the scoring system through the myriad My Choice panel, which is basically looking at scoring up these mutations to add up to whether or not they benefit from PARP inhibitors or not. So realistically, you need that as early as possible. The problem is how much tissue you need to be able to get those tests done is quite a lot. So to get somatic HRD panel, you need at least 3 good 16-gauge core needle equivalent of tissue. So if someone hasn't had surgery, getting a simple sort of acidic fluid tap to get your diagnosis might not be enough to actually do the full panel testing. And sort of it also will push us towards asking, even if you can't resect someone, sometimes asking the gynae-oncs whether they're going just to get tissue so we could get proper panel testing. Because you can't really predict who's going to be platinum resistant sensitive, I think the best practice is to try and get your tissue answered straight up. And even if it takes time to get the results, that if you've started your chemo, that will take 3 and a bit months anyway. So by the time your chemo is done, realistically, you're pretty close to getting your results. And then you can go on to your maintenance path if they qualify, otherwise just surveillance.
Vish, it's almost like you've got these notes in advance, because that was exactly going to be our next question about the intricacies of HRD and its part alongside BRCA. I guess the other biomarker, quote unquote, that has gotten a bit of attention, particularly recently in the, not necessarily the ovarian or primary peritoneal space, but more the endometrial space, is deficiency in MMR and the use of immunotherapy. We had Ruby and the NRG trial of Pembro. So dostarlimab and Pembro basically on the same day in the same edition of the New England Journal of Medicine. How do you think that immunotherapy, and you can speak as broadly in the gynae space as you want, but using endometrial cancer as a sort of a jumping off point, how do you think immunotherapy will start to affect practice in gynae-onc as well?
I think with endometrial specifically, I think the dMMR population, the data looks very much on par with what you'd expected based on dMMR, colorectal other cancers as well and their response rates. So interestingly, there's a recently been PBS approval for combination of pembrolizumab and lenvatinib for relapsed endometrial cancer post-platinum. So the data set was in pMMR in the trial, but interestingly, on the PBSE, it doesn't actually say that. So you can technically access it for all endometrials in the second line now. And then you sort of go, well, if you've got dMMR, what is the extra benefit of the lenvatinib? But that's the sort of treatment approval that we've got at this point. I think, dostarlimab specifically, I think they're trying to make a really good case to try and get registration in the dMMR endometrial space first line. I think biologically that's a different group altogether. And, it could be nice to see if you could actually even replace chemotherapy altogether just with IO for certain patients. I think there's a few sort of good driver predictors of treatment, and dMMR is certainly one of them with regards to endometrial. Then the question comes about, is that the be-all and end-all? I know there's some of my colleagues also checking, well, most of us actually checking for HER2 as well in the endometrial space, and I've certainly looked after a few patients who've ended up self-funding trastuzumab in that setting as well. So I think immunotherapy will sort of have a big role to play in the endometrial space, whether it's combination of lenvatinib with the pMMR or the dMMR's sort of monotherapy. Unfortunately, the trials in ovarian has not been as successful, even in combination. I think in the lower gynae tract, though, there's potential. So there's been data with cervical, certainly, with combination chemoimmunotherapy. So I think it's also got a role to play in that space, and probably a bigger role, because if you sort of map what immunotherapy has done in sort of squames in other areas, there's potential benefit that's there. The challenges in those areas, though, is that these are rarer cancers. It's harder to get a good trial, and it takes time to read out. So it's still going to take a few years for us to get access, I suspect.
Vish, with the dMMR or other such biomarkers, what do you see as the main utility of tumor markers? And the second part of my question, I always see sort of dMMR or these markers a little bit coarse. We know there's going to be a certain group of these patients who will respond, and there's always going to be some that will respond, whether they're proficient or deficient. I think the first part of my question is using tumor markers as a predictor of response. And the second question being, are there any sort of future research or areas that you're aware of that might help us navigate one of the challenges that's selecting patients for use of these treatments?
So I suppose tumor markers we look at, it's always nice to look at a number. So if you think, but the thing is, if you've got a tumor marker, so we're talking typically going to be CA125, although some patients it might be the CA19-9 or the CA, that's up. If you've got a marker that you can actually watch and is actually consistent, sort of mapping what the cancer's doing, it's quite sort of tempting to keep looking at that and making treatment decisions based on it. There's a couple of caveats to that. So I think our surgical colleagues use that a lot more in someone who's unresectable at the start for ovarian cancer, for example, and looking at the sort of imaging response and biochemical response to make a decision about interval debulking. And I think that's a different setting. I think when we're sort of making treatment decisions, you always need to remember that, it's not 100% science. So even if the tumor marker was responding, and certainly most of us will tell you we've got patients where the markers are looking great, you've had them finishing their chemo, and then you do a scan, it's actually looking worse. So cancers de-differentiate sometimes and stop secreting CA125 as well. So you generally I usually tell my patients it's 2 of 3. So we kind of need to look at 2 out of 3 things to agree on what's happening. You've got markers, imaging, and symptoms. And so if 2 out of 3 are in agreement, we tend to be happy with that. But if, one's out of sync with the rest, and you've got patients sometimes where how I make decisions. So a concrete example, let's say, for example, you've had a patient who had their debulking, had their 6 cycles of chemo. They're not, actually, we don't even know what their HRD status is because this is a while ago and we didn't have testing. And we're basically just observing them. So we're doing CA125 just to sort of monitor and make sure that we don't need to do imaging. I don't tend to do routine imaging. If their markers were up before, I tend to track the marker. And once it starts to change is when I tend to initiate imaging. So you sort of check, CA125 sitting at 15, then 17, and then next visit, which is about 6 months later, right on that edge, it's now 200, and their baseline was about 9,000. And so at that point, you do a scan, and the scan doesn't show much, and the patient feels well. Do you change treatment then? And my default is I don't treat a number, I treat a patient. So the reality of it is their cancer is incurable from the get-go. So starting treatment early, if they're asymptomatic with nothing that's changing on scan, is not really going to change the end game. So you might as well wait. And, a lot of people will tell you that have patients where they're waited and the marker keeps going up, but there's no detectable disease. And so until there's symptoms or change on scans, and then you sort of can initiate another line of treatment. And then it gets a bit harder. Do you call that patient platinum sensitive or not? And so biochemically, they're progressing beforehand, but radiologically not. So, you sometimes try it and you might find that they're not actually that responsive to platinum. So that part of that. And your second part of your question, sorry, Josh, I've forgotten.
That's okay. It was a bit of a winded one. The second part is looking at other biomarkers or markers that we could use to, I guess, predict response, things like dMMR or pMMR or tumor mutational burden or things such as that might be emerging in the field of the gynecological world.
Yeah, look, I think there's actually there's a volume, there's actual labs all devoted to cancer biomarkers in the ovarian cancer space, but I don't think there's anything that's really made it into clinical practice. And, it is still very much, it's interesting that someone who secretes CA125, that's still a very good predictor of where we're going. And those that don't tend to fall back on imaging. There's not really a clear-cut way. And I was recently at a sort of meeting around using PARP inhibitors, and even the guys who've sort of pioneered the way for this sort of use the sort of disease-free interval on platinum as their default to determine if they can't do testing whether someone might benefit from a PARP inhibitor or not. So a lot of it is still, unfortunately, clinical.
And Vish, we're sort of at the stage now where immunotherapy, I'm going to sound like for want of a better word, a millennial here, but immunotherapy is sort of becoming yesterday's news, and the new hot thing is antibody drug conjugates in many cases and various targeted therapies. As someone who very much has his ear to the ground and he gets a lot of backroom chatter about potential things that are coming, do you have any insights as to what might be the next big thing, even just sort of in general terms, for gynae cancer? Is there anything that you're particularly looking forward to that's around the corner?
I think I think we separate that again into the different components. I think if you're looking at the ovarian sort of high-grade serous populations, clear-cut sort of what happens post-PARP is now the biggest challenge. So, potential trials coming up with drug antibody conjugates kind of targeting that particular pathway and pathways of resistance. I've heard of a couple. It's still very early and we're still not quite sure. It's taken a very long time to get any kind of innovation from a therapeutic perspective in this space. But I think now that we know a lot more, we'll probably find a bit more targets. The platinum-resistant group is also an area with a lot of interest at the moment. So there's potential with sort of pathways of resistance that have been discovered, and there's been a couple of positive trials that haven't read out just yet, but anecdotally there's been a couple of patients who've been on those trials who've done really well on second-line therapy instead of chemo. So that's coming up soon, and I think it's a novel target. I just can't remember the name of it. But there will be a bit more probably. I think the next barrier to come down will be the platinum-resistant group and the ones with no mutations, because I think PARP is changing the game with regards to HRDs completely. And so there's sort of two arms in that area of what happens post-PARP in the HRD population, and the other component is the platinum-resistant, which is gaining a lot more attention about pathways of resistance and how to overcome it. I think, we use chemotherapy. I can think of God knows how many lines of chemo I can throw in this space, but it's the rule of diminished return every time you give something, it doesn't work as well. I think one of the challenges is that we sort of don't really biopsy on progression in gynae cancers, whereas we do in other cancers. So I think we need to change our mindset as well over time around that, and potentially rebiopsying on progression to determine the next course. In the sort of, I think immunotherapy has been more exciting in the endometrial space, in the sort of squamous cell space in the lower tract. Not many things are coming. I think immunotherapy, we're sort of waiting more on what happens with immunotherapy, to be honest.
I think we have two things I can agree on as we wrap up. The first being that Michael is definitely a millennial. The second part is that there's a lot of work that still needs to go into the ovarian and the gynecological space, but hopefully as new drugs are tried and tested, we'll have further options in that post-PARP world. If you had the ability to talk to your younger self, when you started this journey, whether that be med school or being a specialist trainee or even a junior consultant, what pearls of wisdom would you have for a trainee, or what sort of things have you learned over the years that would be like, I wish I knew that, 10 years ago?
Look, there's many things that you could probably think of that you could improve on, but I think it's important to appreciate the journey that you're on, and don't take things for granted. Learn off your patients. Life is precious. A lot of our patients will not survive beyond, a short amount of time in the advanced setting. And I think, remember something that, we all want to have great careers and contribute and help, but don't do that at the expense of your own life. Speaking from someone who's had an episode of career burnout once, I think if I had to talk to my younger self, it would be, don't overstretch yourself. Learn to say no sometimes. Don't always agree to do things, and push beyond what you can do, and listen to yourself. I would also, my journey's been sort of not ad hoc, but it's kind of taken me in different places, and I wouldn't change that part of it. I think that's actually helped me gain experience, and you can learn something of everything that you do. Even if you're working in a setup where you're not that happy, there's something you need to learn from that, is how not to do it, and how you would do it when you have that opportunity to change something yourself. I think the biggest thing for me is, and something I tell myself all the time, is learn off the patient in front of you. Like, don't miss opportunities in your life. So if there's, when you look back on what matters, your career will matter, but probably won't matter as much as family. So what I've learned is to make that more of a priority in my life.
A brilliant note on which to end. Vish, thank you so much for spending some very quality time with us, each sentence dripping with dense wisdom and very practical advice for anyone listening with an interest in gynae cancer. So thank you so much for coming on.
No worries. Thank you for having me.
So join us next time on Oncology for the Inquisitive Mind, where we will have a very belated examination on triple negative breast cancer in the advanced setting. We've looked at the exciting space of neoadjuvant treatment with immunotherapy coming to the fore, even for us millennials, as I've been outed. But we will be looking at the frequently much more challenging space of metastatic triple negative breast cancer. So we'll see you next week.
See you then.
Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.